I continually forgot to turn the microphone off. I've succeeded in this occasion. Thank you for your introduction. Perhaps I should declare an interest in that I trained at the Westminster, now defunct, Hospital of Wend. I actually worked at the Princess Beatrice, the Hospital of Wend. And I did my obstetrics at the West London Hospital, the Hospital of Wend. And I just couldn't bear it to happen at the Charing Cross where I did my postgraduate training. In fact, like our council leader, I have good reason also to be grateful to the Charing Cross Hospital. Not only because it provided me with several years of employment as an educator and as a postgraduate student, but also because, yes, I've been operated there, and I also have good reason to be, my friends and family have good reason to be grateful to the hospitals, other hospitals under threat, such as Ealing, who also looked after it as an emergency to my late father-in-law, and even I've been through their A&D in the crisis there, so perhaps that's my interest. However, I did approach this as independently as I can, and I prepared, not a statement, something that looks tonight, which I'd like to present to you now, which looks at the hospitals facing service closures, the out-of-hours services, urgent care centres, and the implication of the demands facing GPs today in the context of future London healthcare and for what we've come to describe as SaHF, not shaft, but S, shaping a healthy future. Now, you'll have noticed that shaping a healthy future affects areas of high deprivation more than low. The maps in the report illustrate this in respect to the A&E departments. According to SaHF, Ealing, as we've heard, Ealing and Charing Cross are to become local hospitals. As with urgent care centres, it's proved very difficult to pin down exactly what is meant by that term. Now, for example, a local hospital may be an outpatient clinic with a UCC, that's urgent care centre, attached. Alternatively, it may retain a limited number of beds. I've heard it suggested that these might be used to tide over the elderly who have acute illness not manageable at home. However, as we heard one witness say, vehemently say, that would be to deny them the ready access to all the specialities of the acute hospital, including intensive care. In fact, he described it as discrimination. Now, the hole in the SaNH SaHF, I'll call it again, map, where the most vulnerable live, compares with the concentration of hospitals in the much less deprived inner London edge of the area that we're looking at. So, those less able to cope with limited means and maybe limited language are going to have to go farther and negotiate more difficulties in travelling to hospital. For a Southall resident, perhaps with children in tow, getting to Northwick Park to visit a relative is an obvious challenge. Patients will still need to attend specialist centres. Thought has to be given to equity and fairness. A nagging question for me is this. In fact, it's a bee in my bonnet. If great London teaching hospitals such as Charing Cross, St George's and Westminster could move to Fulham, Tooting and Chelsea, why can't St Mary's move to Ealing? Already available there is the land, the transport links, good transport links. That's why rioters went to Ealing. Our consultants described Ealing as the most efficient hospital in London. Maternity services could be expanded within the Ealing site, recovering the special skills of the Ealing maternity unit. I recommend you to read the report, where you'll get a flavour of what the staff and patients were saying about what is now the disappeared Ealing maternity unit. For patients of the old St Mary's, the trains still run in both directions, giving easy access to new St Mary's at Ealing. if they preferred not to travel, as the vulnerable people who attended the Ealing maternity unit are expected to do now, they would still have local to them Chelsea and Westminster, or even UCH, and of course Charing Cross. The original St Mary's could become a local hospital, whatever it is. Valuable land would be freed up, with no need to build on such an expensive and confined area, and the Fleming laboratories could be treated with as due respects that they deserve. I don't go as far as one witness who said she believed it to be a consultant's private practice influencing where hospitals are centralised. I don't actually believe that, but it was said. However, I can't help wondering about the influence associated with such institutions as St Mary's in Chelsea and Westminster. Admirers of Churchill, Winston Churchill, will know what I mean when I call it the Lord Moran effect. Now, out-of-hospital services have to work for SaHF to work. The logic is that they will prevent admission, reduce the strain on emergency services, and reduce the need for expensive acute facilities. Now, of course, in themselves, out-of-hospital services are a good thing. I have personal experience of running outreach clinics. I know the benefits and I know the difficulties, and sometimes the inefficiencies involved on just one side. To organise them on a regional basis is a tremendous endeavour. And so it's not surprising to find out that as we did, that the out-of-hospital process is developing in a very slow, piecemeal fashion. I can only draw your attention to the comments of Anne Drinkle, which are actually quoted in the report. Where the siting, where they're going to put urgent care centres remains a worry. The public and professionals are confused over a difference between them and an A&E. We heard the distressing anecdote of a case in which delay, whilst waiting for an ambulance to take a patient from a UCC, urgent care centre, to an A&E may have contributed to that patient's death. The report lays out the implications ranging from possible delayed diagnosis and treatment to the extra burdens on the ambulance services of not having UCCs coexisting with A&Es. The argument of several witnesses, including the representative of the Royal College of Emergency Medicine, was that in London particularly requires the location of UCCs within A&Es. Even the most fervent supporter of SaHF must accept that success depends on a well-resourced and expanded primary care service. We don't have one, in particular because of the already increased workload on GPs. In respect of GPs, to quote one witness, they have been taken out of consulting rooms, they are sitting now in CCGs, commissioning groups. There is a huge GP commitment to management, even by those who are not actively involved in CCG work. Increasing regulation, monitoring and top-down supervision, all of which may be to a good purpose, combine to create an often intolerable burden. I know GPs have to cope with a blizzard of electronic communication in addition to the essence of their work, that is what goes on in the consultation. Older, experienced GPs are bailing out, and the young are reluctant to take up the responsibilities of the partnership, many preferring a salaried role or the uncertainties of locum work. A few years ago, a partnership vacancy would prompt at least 80 applications. Today, a practice is lucky if it gets one or two. If the out-of-hospital services are to get anywhere, there has to be an increase in resources with more GPs and primary care staff. Now, two specific concerns are worth mentioning. Hollowing out is the first, a process applied to the Central Middlesex A&D and Ealing maternity unit. basically is this. We are told an institution is to be closed because it cannot be staffed safely or to modern standards. Now that's an argument at first sight difficult to contradict. But of course, if you suggest that at some time in the future a department or even a hospital may close, people will not apply to work there. Who will move his or her family to a hospital knowing that there is to be no job in a few years' time? In this way you can precipitate and then justify a closure. It amounts to a variety or a variation on planning blight. The second concern is regard to the scarcity of responses from practicing GPs. As the report comments, it could be due to debilitating workload, but more worryingly, may be due to the wish not to be seen to oppose. When I was still in practice, I remember attending meetings in which a note or a whisper was passed to me requesting that I ask an awkward question. This was because I was near retirement and I would not fear, as the report says, putting my head above the parapet. I have one final thought. In the audience this evening is Dr. George Moses, and he taught me something over 30 years ago. We were discussing, at that time we used to all our own night visits, and I was discussing a difficult diagnosis of whether I should have gone out or not gone out. And George, who is an LMC expert, said, "Stephen, you must always place yourself in a position to make a diagnosis and a decision. I just don't think SaHF has put itself in a position to make a diagnosis or decision." Thank you.